The blood notes, part two. We left off with the pericardium, also called the epicardium, serous membrane that surrounds the heart, keeps it frictionless and lets it beat very easily. The myocardium, myo means muscle, cardia heart, is the main part of the heart. It's the muscle. You can see the chordae tendineae and around where the valves are, there's a little bit of thicker stuff, some connective tissue they call the skeleton of the heart. So yeah, a lot of people eat the heart, they eat the myocardium part, they cut the skeleton or the valves out. So the endocardium is simply another simple squamous epithelial lining of the heart, which makes it very smooth so the blood can flow through pretty easily. If you get endocarditis, as shown in the picture here, itis is inflammation of the endocardium, usually caused by an infection. That causes it to now not be smooth, which would make the blood flow turbulently, which could lead to clots. And when the blood starts clotting and it gets stuck in a special little arterial or capillary feeding either the brain or the heart, could get either a stroke or a heart attack, a myocardial infarction. All right, endocarditis again is an inflammation of the endocardium. It affects mainly the heart valves and can lead to scarring or stenoses. Remember, stenosis is a thick, stiff valve. A stenosed heart valve then causes a sound before the closure. So it'd be like a schlup. Okay, so tachycardia and bradycardia, two heart conditions. Tachy, like a tachometer in the car, you can see the picture on the right, measures speed. So tachycardia is when your heart beats above normal, like about 100 beats per minute or higher. So greater than 100 beats per minute, you got tachycardia. This could happen when you're sick, you have a fever, or there's other nervous stimulants. You like drank a lot of coffee and your heart's just racing like crazy, or you get nervous. It causes tachycardia. Bradycardia is just the opposite. Think of the Brady Bunch, the most boring people on TV back in the 70s. Bradycardia is a slow heart rate, usually below 60 beats per minute. Distance athletes who run like crazy and they have these very prepared hearts, when they're not running, their heart is like on easy street. So it has a great load in its pump, so it puts out a lot of blood per pump and it doesn't need to beat as fast. Or you might have a sinoatrial node. Your SA node is not doing as it should, not acting as it should, or you could have a nervous disorder. All right, atrial fibrillation. When the atria fibrillate, to fibrillate means to quiver and shake. So it's a disorder, about 2.2 million Americans have this. During the atrial fibrillation, that is when the atria quiver, they don't beat effectively. Instead of closing together simultaneously, they kind of quiver and shake as they close, and that bounces blood around. Again, it can throw clots. And if a blood clot leaves the artery and you get a thrombosis or a clot in the brain, it's a stroke. Or if you get a clot in the heart, it's a myocardial infarction, heart attack. About 15% of strokes do occur in people who have atrial fibrillation. So there's a coincidence of this. Angina pectoris. If you say, oh, I have angina pectoris, it refers pectoris to your chest, angina, some pain, recurring chest pain, and that can be caused by forming clots in the arteries. The heart's not getting the nutrients it needs. It's not getting the oxygen it needs, so it starts going to lactic acid overload and on some anaerobic respiration. It starts hurting. Well, your referred pain could be your chest, feeling like really something heavy on the chest, or your left arm might start hurting. So angina pectoris is just that heavy chest pain that could mean you might be having a heart attack soon. The accumulation of plaque on the inner walls of the coronary artery restricts blood flow. You can see in the diagram a plaque there. So throughout the years, all the fatty foods and stuff you eat builds up, starting as a kid. And it builds up and it builds up and it builds up till finally it closes off so much blood can't get through, or it breaks loose and then totally clogs up a smaller section of the coronary artery, and causes a major death of part of the heart. So myocardial infarction, big fancy word. Myocardial means the muscle of the heart. It infarcts, it stops working. Usually, again, because a blood clot or not enough oxygen supply to the heart. Your muscles, if you try to sprint half a mile, you're not going to make it. Your muscles need to be rephosphorylated for the ATP to be rephosphorylated, and they're going to give out. So you need that oxygen. So symptoms of the myocardial infarction, you get the angina pectoris, increasing episodes of chest pain, angina, pain that extends beyond your chest to your left arm, your shoulder, your jaw. That's called referred pain. And we talked about that in the past, that the brain doesn't always hear pain from the heart, so it hears from the same portal that feeds like the left arm and the jaw. You get a lot of pain in your upper abdomen, pressure in the middle of your chest that lasts for a while, shortness of breath, sweat easily. You even get this sense of impending doom, like, oh, you faint a lot, nausea and vomiting, fatigue. So those are a lot of symptoms that could happen. All right, so normal heart. Diastole is when the heart's relaxing. When the heart's relaxing and filling, that's called diastole. Diastole means the pressure of blood out in the veins and arteries and the rest of the body is going to be at its lowest point now because you've got a lot of blood in the heart. When the ventricles contract and squeeze during pumping, you can see it under systole. It contracts, pushing blood out into the arteries, and now the arteries are under higher pressure because they got more blood pumped into them, and that's your systolic blood pressure. So when we measure blood pressure, we say 120 over 80 is in decent blood pressure. Well, that's 120 millimeters of mercury is how they measure the pressure required to open the valves up, open up to let the blood flow through. So the heart is pumping at 120 millimeters of mercury of pressure when it's squeezing under systole, and when it relaxes, there's still enough blood to keep those valves open at diastole at 80 millimeters of mercury. So blue baby syndrome, if you'll notice here, there's a big hole in the intraventricular septum. When the heart beats, instead of routing the blood to the lungs, it mixes. Some blood goes to the lungs, but it's a mix of them. So the blood doesn't get fully reoxygenated because there's a hole in the intraventricular septum which separates the left from the right side of the heart. Again, your right side of the heart takes the blood to the lungs, left side of the heart sends it to the rest of the body. When babies are born with this syndrome, they appear blue. So again, there's a major, it's called a ventral septal defect or tetralogy of Fallot. And that's the big thing. We're at point number 2, the intraventricular septums. Sometimes the aorta is displaced. Their sublunar valve is more narrow because it's not having to work as much because blood flows back through both ways. And you get a thicker right ventricle because now the right ventricle is pumping just as hard as the left ventricle to pump the blood to the rest of the body. So intraventricular septum has a hole in it in tetralogy of Fallot here, which allows low oxygen to get to the left ventricle and back to the body. So only basically half the low oxygen coming back is rerouted to the lungs. And the babies have this bluish, look at the baby's fingers, they're bluish. So they can now do surgery in utero while the baby's still in the uterus and repair this. So electrical activity of the heart, your right atrium up there, RA, has a sinoatrial node, a little clump of nerves in a sinus, little cleft in that right atrium, which sends an electronic pulse out, kind of like in the ships. So the old ships that had to have people row, they'd say row, row. Well, it says beat, beat, beat. So the atria beat, and then you got this little AV node, which will slow things down a bit. They go, actually, the AV node is a second node, but it comes down through the intraventricular septum, what's called Purkinje fibers, and there's a little like resistor there which slows it down just enough that there's a delay between the atria beating, and then the ventricle beating. So the ventricles fill up when they're relaxing. The atria then beat, and they squeeze a little bit extra blood into the ventricles. And as soon as that happens, then the ventricles beat. When the ventricles beat, you can see the bicuspid and tricuspid valves will then close and keep the blood from going back to the atria. So the sinoatrial node is your pacemaker of the heart. The AV node is like a resistor. It slows the pace down just enough before it goes down to the rest of the myocardium, so the ventricles all beat in unison, but right after the atria. So we measure it on an EKG, which you're going to do in lab, and we label these PQRST. What happened to A through O? Who knows? So the P, the little tiny p, represents your atrial depolarization. The muscle is depolarized and it contracts. Those are the atria. They're small. You'll see a better description in your actual lab when you feel a real heart than you do in the pictures here. Atria are small, so they have a little electrical impulse. And then your ventricles are huge, so when they get are depolarized and they pump, they leave this huge peak, the QRS peak. And then when the ventricles are repolarizing, the sodium potassium pumps going getting repolarized to pump again, that leaves a pretty big peak called T. What happens to the atria repolarization? First of all, it's a very tiny peak. Second of all, it is masked by the QRS peak of the ventricular depolarization, so you don't see it. So you can see some EKG strips. Top one, there's a heart skipped a beat. Down below, it's coarse ventricular fibrillation. That means the ventricle is fibrillating. It's not all beaten together, so you get this weird, wacky electrical cardiogram. Oh, this is labeled really nice. So what's number one then? One we said was the Q wave. What happens to the Q wave? Right, the atria depolarize. At two is your QRS complex. That is the ventricles depolarizing or contracting. Three is the T wave where the ventricles are now repolarizing. Four is the time from atria to ventricular depolarization, from the time the atria start to beat to the time the ventricles start to beat. Five is the time from the ventricles start to beat to the time the ventricles are repolarized and ready to beat again. All five very important times for cardiologists to know. So again, atrial pump at P, ventricles pump at QRS, and the ventricles relaxing while it's repolarizing at pump T. And then this little diagram is nice to look at. It shows you a whole bunch of information, more than I'm going to go into. But really the main ones we need to look at are the ones down below. But you can see the lines above show you what's going on while these are contracting and relaxing. It's a nice diagram. If you look at it, it makes a lot of sense. Okay, our virtual heart labs, we're going to do those in class. Again, you can look at blood pressure explained here on the YouTube. I like the way that demonstrates it for you. So A is time from one heartbeat to the next heartbeat. B is the atrial depolarization time. That's the P wave. C represents your QRS complex at the time of ventricle contraction, depolarization. And D is, okay, it's a little bit off, but D measures